Delirium is a very important subject, not only for physicians and surgeons, but also for psychiatrists. Mental health services usually gets involved in management of delirium as a result of very difficult behavior of the patient in general medical or surgical wards and or management and intensive care units. Delirium is an acute, fluctuating change in mental state with inattention, disorganized thinking, and altered levels of consciousness. It is potentially a life-threatening disorder characterized by high morbidity and mortality. It is quite essential to focus on one aspect of this definition, and that is the fluctuating change in mental status. Detection of such fluctuation in the level of consciousness should always alert the psychiatrist or mental health workers to the possibility of a delirium. Delirium is often classified into hyperactive or hypoactive rhythm. Hyperactive delirium manifests with heightened arousals, restlessness, agitation, visual hallucinations, sometimes auditory hallucination, and of course the most difficult aspect of it is the inappropriate behavior, which can be disinhibited, sometimes can be aggressive, and it's always the reason why a psychiatrist is called to assess the patient and over-advise about treatment. On the other hand, we can sometimes see hypoactive delirium. Hypoactive delirium manifests with lethargy, reduced motor activity, incoherent speech, and total lack of interest by the patient. Mixed delirium usually have features of hyperactive and hypoactive that fluctuate. There is another term that is often used in medical practice, and this is subsyndromal delirium. Subsyndromal delirium refers to partially resolved or incomplete forms of delirium. The pathophysiology of delirium has been studied, and the first issue relates to cholinergic deficiency. Probably there is a clear association of using anticholinergic drugs and increased incidence of delirium in psychiatric patients. Surgical studies always point to dysfunctional interaction between the cholinergic system and immune system. Dopamine excess is based on the fact that antipsychotic drugs are always useful in management of behavioral problems, often manifest in patients with delirium. Of course, other neurotransmitters have been implicated. That include noradrenaline, serotonin, gamma-aminobutyric acid, glutamate, and melatonin. There are also issues related to cytokines and the role of interleukins 1 and 2, TNF-alpha and interferon in contributing to delirium. Chronic hypercortisolism as a result of trauma or continued stress can also be a factor in precipitating delirium in vulnerable patients. Delirium is quite common, and can be seen in 15 to 18% of inpatients in general medical and surgical wards. It is also seen in at least 30% of patients following coronary artery bypass. 50% of patients who undergo hip surgery may suffer from delirium, and probably this is related to the older age group. Delirium always raised the possibility of increased mortality and increased surgical complications in the patients. There are many risk factors for delirium, and the first one is older age. Presence of dementia or any form of cognitive impairment would raise the possibility of the patient suffering from delirium. Visual or hearing impairment often interfere with patient perception of his environment and interaction with other people. Functional impairment of any sort and immobility. There is also the past history of delirium, which one should take into account when assessing a patient. Any form of decreased oral intake of food and fluids, and specifically dehydration, raise the possibility of precipitating delirium. Polypharmacy is always an issue, and all the medicines need to be reviewed during the assessment of patient with delirium. Coexisting medical illness, physical frailty, and surgery are all risk factors for delirium. Precipitating factors for the onset of delirium are several. First, there are drugs, sedatives, narcotic, anticholinergic, multiple drug use, and alcohol. There is also the problem of overdose with tricyclic antidepressant, overuse of stimulants, opiates, corticosteroids, analgesics, cardiac glycosides, and anti-Parkinson drugs. Primary neurological injury in the form of stroke, intracranial bleeding, and meningitis can be a precipitating factor for delirium. Acute illness, such as infection, cardiac illness, hypoxia, shock, dehydration, fever, constipation, and iatrogenic complication, are often witnessed in patients who suffer from delirium. Metabolic abnormalities, surgery, environmental factors, including the use of physical restraint, use of catheters, invasive monitoring, and intensive care unit stay. Pain on its own can be a precipitating factor for delirium, as well as prolonged sleep deprivation. Benzodiazepine withdrawal and alcohol withdrawal are often seen in younger patients. The use of physical restraint is quite an important issue in patients admitted to psychiatric intensive care unit, and should always be kept in mind that patient might suffer from delirium following excessive use of physical restraint for a prolonged period of time. We move now to the clinical features of delirium. There is always a prodromal phase characterized by restlessness, irritability, and anxiety. And then there is the acute onset, and I stress again the fluctuating severity of the delirium. There has to be cognitive impairment, which can manifest as attention deficit and memory impairment. Patients are often disoriented for time and place, and there are impaired visual constructional ability and impaired executive functions. We continue with the clinical features of delirium. We always find thought and speech disturbance when examining the patient. Illusions are quite common. Hallucinations are often visual rather than auditory, although both can be seen. Misidentification of other people, including close family members. Psychomotor disturbance, as we referred to in the classification of delirium, can be either hypoactive or hyperactive. We continue with the clinical features of delirium. Thought and speech disturbance can be easily observed in patient during examination. Illusions are quite common. Hallucinations are often visual rather than auditory, and misidentification of others is quite common. Psychomotor disturbance can be witnessed in agitation, hyperactivity of the patient, or sometimes you'll find the opposite completely, where the patient becomes very lethargic and hypoactive. There is always disturbed sleep-wake cycle and marked impairment of patient 24-hour rhythm. This can manifest as severe insomnia and drowsiness. Delusions are quite common, and there is always a paranoid process that might lead to violent behavior. Affective disturbance are often witnessed and so variable. It could be fear, crying, and anxiety, panic, rage. On the other direction, there is sadness and apathy. Sometimes you might find that the affective disturbance is totally incongruent to the patient status of health. Delirium needs to be diagnosed, but also there is always the need for urgent consideration of the cause of delirium. This is very important sometimes in clinical practice. New onset of neurological disease and myocardial infarction are important. Severe system infection and sepsis are important in patient, older age group. Alcohol abuse is important as well in psychiatric practice, in patient admitted and withdrawing. Of course, hip fracture is quite common. Glucose abnormalities should always be considered in any patient manifesting with any form of delirium. And it doesn't take more than a few seconds sometimes to check the glucose concentration. Drugs withdrawal and toxicity are important. Sometimes drug toxicity is quite common in patients admitted to mental health units. You find always the patients are young, have a past history of abusing illicit drugs. Acute psychosis, malignancy, hypoxia are important factors, and urinary tract obstruction should always be considered in patient admitted to mental health unit. Anticholinergic drugs sometimes do not help and might lead to urinary tract obstruction. It's often better to refer the patient urgently to accident and emergency for resolving this issue as a matter of urgency. It is not easy to remember the causes of delirium, but sometimes in psychiatry we use the letters WHHHIMP. The first W refers to Wernicke's encephalopathy. Wernicke's encephalopathy is an emergency, and any patient presenting with any form of delirium should be given thiamine, IM. H refers to hypoxia, hypertensive encephalopathy, hypoglycemia, and hypoperfusion. I refers to intracranial bleeding, infection, while M refers to meningitis. P refers to poisons or medication. Poisons include, of course, illicit drug abuse. Sepsis should always be assessed, and they use the SOFA score in intensive care unit. The score of more than 2 always means there is a possibility of organ failure. So you assess respiration, coagulation, liver function, cardiovascular function, central nervous system, Glasgow Coma score, and renal function. Treatment of delirium is treating the cause of delirium. Most patients would require to be observed very closely, but mental health services are often consulted when there is aggressive behavior and difficulty in controlling the patient. Haloperidol is probably the most appropriate medication to be used. It can be given orally in a dose of 5 milligrams, or it can be given intramuscularly. It is always important to check with the treating physicians about the metabolic status of the patient. Also, one has to be careful about raised level of creatine phosphokinase, which may indicate the possibility of a neuromalignant syndrome. There are some psychiatrists who prefer the use of quetiapine. However, quetiapine is difficult to administer because it's always given orally. Also, the dose needs to be titrated very carefully, starting with 25 milligrams twice daily and increasing gradually to 50 milligrams twice daily, 100 milligrams twice daily, and so on. Now, that type of management is rarely practical in intensive care units, and haloperidol can be very rewarding if it is used appropriately. Of course, the dose of haloperidol is different with the elderly, and it's always preferable to start with 1.5 milligram orally, and that might be enough in most patients. Of course, the use of benzodiazepines can be quite controversial. Sometimes there might be difficulty in giving haloperidol, or it is contraindicated. But if the patient is being assisted in his respiration or on mechanical ventilation, and there are facilities for mechanical ventilation, the lorazepam dose of 1 milligram IM twice daily can be very helpful in controlling agitation. The maximum dose of lorazepam should not exceed really 4 milligram daily, but there are in some units a much higher doses can be used to control difficult patients, especially the younger age group. So always reserve the benzodiazepine to the younger age group and avoid them completely in any patient who would require assisted ventilation.